Hello, I'm Norman Swan. Welcome to this programme on preparing for the influenza season. Tonight we'll be talking about the strains we will face this coming flu season, and we're not just talking about the strains of influenza here. We're talking about vaccine safety, support for health professionals, prevention, the new NIP schedule, barriers to successful vaccination programmes, the difference between a cold and the flu, I bet you'd like to know that, treatment and who the at-risk groups actually are. We're funded by the Australian Department of Health and Ageing to do this programme tonight, for which we're very welcome, and you'll find a number of useful resources on the Rural Health Education Foundation's website, rhef.com.au. But let me introduce our panel to you. Professor Robert Boy is Head of Clinical Research at the National Centre for Immunisation Research and Surveillance at the Children's Hospital Westmead in Sydney. Welcome, Robert. Robert's worked in the UK in paediatric infectious diseases, and his research interests include the epidemiology and prevention of paediatric infectious diseases such as influenza. Rachel Dinar is a practising community pharmacist, currently working in the rural setting of Dodges Ferry in Tasmania. Welcome, Rachel.
Thank you.
Where is Dodges Ferry?
Dodges Ferry is on the way down to the Tasman Peninsula, down the southeast of Tasmania.
Welcome.
Beautiful part of the world.
I'm sure. Rachel has been working at the University of Tasmania and heavily involved in outreach programmes, as you'll hear, particularly in relation to immunisation. Leanne Jones is a general practitioner working in Launceston, Tasmania, been in general practice for many years and is a member of the Influenza Specialist Group. Welcome, Leanne.
Good evening, Norman.
And Karen Lajoie is an immunisation nurse consultant from Melbourne. Welcome, Karen.
Thank you.
She's currently president of the Immunisation Nurses Special Interest Group and a member of the Influenza Specialist Group. And on the phone to us tonight from Canberra is Professor Jim Bishop, Chief Medical Officer and Principal Medical Advisor for the Department of Health and Ageing. Welcome, Jim.
Good evening.
So welcome to you all. Look, just give us a primer here, Robert. When we talk about A, B and C, what are we talking about, and does it make a difference to the general practitioner?
Influenza is a virus which is typed as 3, A, B and C, but C we can dispense with straight away because it's virtually never seen in humans. It's A and B that matter, and in terms of A, there are many different types. The ones that we worry about particularly are AH1 and AH3. In terms of B, there are a few different types too, but we only have one type in the vaccine. Maybe in the future we'll have 2.
What's circulating at the moment, Jim Bishop?
Well, we know what's circulating in the last Northern Hemisphere winter, and it's a bit of a mixed bag, but it's all covered within our influenza vaccine. And in Europe, H1N1, the pandemic H1N1 predominated. In the United States, it was mainly H3N2, and then obviously B has been important in China. And I think that we, based on our own experience, we would expect that all of those types might be important, but particularly perhaps H1N1 this year again.
And Robert, people don't realise that the circulation goes by hemisphere and it comes back via Asia. We don't get the northern unless it comes by jet. We don't get the northern one here. It by and large mixes in Asia before it comes back down to Australia. That's
right. China's especially the place where there's a co-location of a lot of pigs, a lot of people and a lot of ducks. And that leads to a mutation in the virus, and the new viruses tend to come out of China. And then they spread across the Northern Hemisphere, and then when the new winter comes, we get it in Australia.
So what's surveillance in China telling us we're in for, given that circulation is going to come down here?
Well, Jim's already said that they've had some bee disease, and so certainly we could expect some bee disease this coming winter. We're ready for that with the vaccine, but I think we'll have AH1, as Jim says, and probably some H3 too.
And what about bird flu? Is that still around?
Bird flu is still around. It's not something that's going away. It's very hard for it to transmit from animals to humans, and that's good news, because when it does transmit, it has a 50% fatality rate. Indonesia and Egypt are the main places where there's still a problem.
And what we're worried about is a reassortment, which hands on the virulence.
Yeah, it's been trying to do that for 18 years, so we're hoping it won't do it.
Just hang off for the time being. What was the impact of influenza last year and the year before, Jim?
Well, as you know, the 2009 year was when we first saw the swine flu pandemic H1N1, and really we had a lot of infection that year. You know, we've talked about the 700-odd people that ended up in ICU that year with that infection, and a lot of hospitalisations. Now, following the monovalent vaccine and then the seasonal flu vaccine last year, which included the pandemic H1N1, we had a very quiet year last year. So from 700 odd ICU cases, we were able to identify about 60, and the number of admissions also went down. And so that was what we might expect with all that degree of vaccination around.
Sorry, Robert?
Oh, I think it's a real credit to the Australian health system that so many people were vaccinated, first with the pandemic and then with the seasonal vaccine, that Australia was one of the few countries in the world where its second wave of the pandemic H1 disease was almost trivial.
Leanna, did you notice that in practice last year?
Certainly in practice we saw a lot less people with symptoms of an influenza-like illness, and we had a good response to having the vaccination, which I think certainly it showed that it helped. People were very interested in receiving the vaccination last year.
Rachel, do you expect the interest to wane this year, given that we're coming off the crest of the pandemic?
Look, we've already seen just as many people being vaccinated through, certainly in the area where I am. You know, it's one doctor and he's been extremely busy, so hopefully the same trend will continue.
Robert, just again, so just in case we're not absolutely clear, the difference between seasonal and pandemic flu.
Well, the last pandemic before the current one was 1968, and that was H3N2. That virus then became, over the next couple of years, the seasonal vaccine, and most years over the next 40 years, H3 was predominant. So within 2 years of having a pandemic, it just becomes the seasonal strain.
But the seasonal strain, so the sense was that during the pandemic, such as it was in 2009, I might ask Jim this question, there was this, young people, pregnant women, rather than the usual pattern, which is the elderly and the chronically ill. Has the seasonal pattern returned to its traditional pattern, or are we still seeing pregnant women, young people being particularly at risk?
Well, as you said, in 2009 it was very much, as you see with each pandemic, the effect much more on younger people and less so on older people. Last year we saw an intermediate picture with a little bit more in the older age group and a little bit less in children. So I think, as Robert's talking about, we're seeing a return to a normal pattern. So I can't predict it exactly this year, but I would expect it would start to move towards our normal pattern.
And Jim, what difference does travel make to it when we're talking just about regular seasonal influenza? Is it just the odd person coming off a jet and it's not really making a big difference to a country of 20 million people, or is it starting to have an influence?
Oh no, I think that we'd see with so much travel these days, flu now flies around at the speed of a jet plane. In the old days, of course, we could isolate flu off North Head in Sydney. And so those days have gone, and we would expect that flu from all around the world would come into Australia fairly quickly. And that's the case right around the world. The WHO has said that really usual country borders are not really relevant to a flu. It will spread around.
Jim, there was a meta-analysis a couple of years ago, I think it was in The Lancet, which suggested that there's no very good evidence that vaccines prevent what you hope in seasonal flu, that vaccines actually prevent hospitalisation and mortality. They certainly prevent influenza, but that they don't prevent the effects of influenza. Do you have any data to support vaccination for those effects?
Well, we've seen a real-life experiment, David, that I've quoted already over this last couple of years. We do know that we had this large initial wave which got around, let's say on average, 20% of the population with natural immunity. In other words, they got their immunity by getting the flu. But then on top of that, we had a fairly extensive vaccination program, and that would have pushed the number of people that would have had some immunity with the vaccination right up. And we've seen the effect. In other words, the reduction in hospitalisation, emergency department admissions, ICU admissions, I think are good examples. Now, I think we've seen that pattern around the world where vaccination has occurred. So I think we've actually identified a whole new set of data based on our most recent experience, that vaccination works.
Leanne, there's been a whole issue about safety, particularly in children. So during the immunisation which came on stream during the pandemic, did you notice any increase in febrile fits in the children you were immunising?
Not in the children I was immunising, but a lot of them were having just the pandemic vaccine, and then we had a smaller number having the seasonal vaccine. And I personally didn't see an increase in numbers, but anecdotally have heard other doctors say they were experiencing that.
What was the story there, Robert?
Well, it depended on which vaccine you got.
So it was the CSL vaccine that was the problem?
That's right. Unfortunately, the CSL vaccine last year, the way it was made, had too much neuraminidase. One of the components was far too much in excess, and that caused fever and then febrile convulsion. And when we compared that vaccine with other vaccines available for children last year, the rates of fever were dramatically higher with the CSL vaccine, as were the rates of febrile convulsion. Unacceptable. The Chief Medical Officer, Professor Jim Bishop, took the step, I think on April the 23rd, to stop the program for children. And then after a few months we knew what was going on and could resume with the vaccines which we knew were safe. The same ones that we're using this year, they're safe.
So even the CSL vaccine, Jim?
Now, what's happened this year is CSL vaccine is not registered for children under 5, and we've had advice from our expert advisory group which would tell us that our preferred vaccine up to the age of 10 would not be the CSL vaccine between 5 and 10. So we've got good vaccines that we've got good experience from last year, lots of data now about the side effects. So we're going for the vaccines, and we've made recommendations that we know don't cause this problem in children.
And Karen, we see the vaccines that people are available for people. Who are the groups who are getting it under the National Immunisation Programme?
Well, Jim's actually said which ones are for the under 5s. Anyone that's over 65 is funded under the National Immunisation Program. Also, Aboriginal and Torres Strait Islanders greater than 15 years of age. Anybody with a chronic condition that predisposes them to severe influenza, and particularly pregnant women.
Which chronic conditions, Leanne?
Those chronic conditions would include diabetes, renal problems, heart disease, something that might affect your immunity, such as chemotherapy following cancer. If you've got a neurological condition that affects your respiratory system, chronic respiratory disease, I don't think I included that one. Yeah.
Jim, what procedures are in place for monitoring the vaccine safety this year?
Well, last year you could argue that in the sense that we got a very early signal, which was the first noted around the world with respect to the CSL vaccine, Fluvax, in children. That was reported and acted on, as Robert said, fairly quickly. And so that reporting system has been in place for 40 years. We think that there needs to be a greater awareness of it because we think it works well when people use it properly, and that will be in place this year. For new vaccines, we are asking the companies to be more active in terms of their own information they provide the regulator, the TGA. But we've really got a whole year's worth of large numbers of patients where we have all the information. So I'd be very surprised if we identify other side effects that we don't already know about based on the large experience last year.
And is there much variation state to state and between jurisdictions on how it's reported?
Not really. I think that we've got a very good system with the Australian Health Protection Committee. What that does is have all the CHOs as chief health officers together, and we can talk about surveillance, we can talk about reporting, and there's a high awareness amongst the jurisdictions, the states and territories, about the need for this, and we find that there's a good cooperation. So I think that we'll see increasing incidents and of reporting on the basis that we've gone out and asked for more adverse event reporting.
Robert, there's been a suggestion, I mean, I think it's fairly well documented that having a live influenza vaccine gives you very good immunity and it gives you longer lasting immunity than any vaccine currently available. But there's been a suggestion of that there's maybe some harm from vaccination, that people are perhaps more exposed to infection the following year. What's the story with this?
Well, very quickly, there is data from people born around the time of the 1918 pandemic that they still had immunity in 2009 because the H1 was so similar between those two pandemics. The story now is that there's been concern over safety Just repeat.
Well, this is the story in Canada where perhaps people were more vulnerable to swine flu the following year.
There was concern that having had a seasonal vaccine a few months before the pandemic started, that you were actually at increased risk of that viral infection. Now, that was a case control study. It did not control for socioeconomic status. So richer people might have got vaccinated, they might have travelled more, they might have had dinner parties, they might have spread the virus, and it might have been a totally different scenario. So you need a randomised controlled trial. Fortunately, we have one, and we know that there was actually moderate protection in Australians against the pandemic from having previously had the seasonal vaccine. Now, that's not confounded. It's a randomised, double-blind controlled trial. So the Canadian data, based on case control information, although extremely interesting, has probably been confounded and therefore inaccurate.
Do you want to comment on that, Jim?
Yeah, look, I think we've got conflicting evidence, and I think the best evidence is the one that Robert has mentioned. But really, there is evidence both for and against if you look at all of the studies. And so I think there's biological interest here about how vaccination might differ from natural immunity. It certainly isn't a piece of information that we need to take into account when designing vaccine programs. We still want to keep people out of ICU. We still want to keep people well, and the vulnerable groups we want to protect. So that will always be the case, and the best approach must be vaccination.
Jim, thanks very much for joining us.
Thanks very much.
What's the difference between cold and flu, Leanne?
This is a common misconception in the population. The public come in saying, I've got the flu, and they've just got a little bit of a sore throat. They're a bit miserable, often still trying to attend work, go about their daily functions. And there's the other extreme of the severe flu. People are often totally bedbound, have trouble getting to the surgery, often request a home visit. They've got a high fever, they're very miserable. Sometimes they may have some gastrointestinal symptoms of diarrhoea or vomiting. And then they clearly have got an influenza, and the other group have clearly got a cold. But in between, we have those people who have a mixture of symptoms, and some of them probably will have influenza, and we may not pick that up.
What about people who just got a frank cold? Do we know what proportion of them actually have the flu?
Oh, probably of people who have a frank cold, 5 to 10% have influenza.
So even at the mild end of the scale?
Influenza accounts for much more of the severe end of the scale, but when you look at influenza in its entirety, more than half of it is pretty mild.
And particularly in children, isn't that, Robert? The children often will only have mild symptoms and maybe therefore passing it around the community.
Yeah, absolutely. They think it's something to do with innate immunity dealing with it rather than humoral adaptive immunity, but that's something that we don't have time to go into here.
I'm sure that pharmacists would agree that it's extremely difficult to make that differential diagnosis sometimes, and I guess if in doubt, phone a friend.
If in doubt, do a swab. I mean, what's the story here with swabs? When should you actually bother with a diagnosis?
I think if you're concerned and they're in one of these at-risk groups and there's a risk that they may be hospitalised and you want to have some information early, so doing a swab. If you're suddenly starting to see this and you're perhaps in a sentinel practice, we have a system called aspirin, which is a number of practices across Australia are trying to pick up presentations with influenza-like illness, so they can sort of see that, warn other GPs in a way if the peak is coming. So doing the swab can be useful then. Or if you've got a traveller from overseas who's presented with an influenza-like illness, that may be something as a public health issue. And Robert, I believe in practice where I work, this takes 2 or 3 days to come back. By then the patient's on the improve, but I believe there is a rapid test that you do
there
in
are
hospitals.
rapid tests available, and they take only 10 to 15 minutes. It's just a nasal or a throat swab, probably better a nasal swab. And any idiot such as me can do it. The sensitivity is about 75%, so you perhaps miss a quarter. You're
still going to miss somebody.
You're going to miss a quarter of them, but the specificity is about 100%. So if you find flu, you know it is flu.
But it's not covered, unless you're working in a hospital.
No, you've got to pay for it. It's $15, so it'd have to be passed on to the patient.
What side effects can we expect from the vaccine, Karen?
The vaccine is pretty well tolerated. The most common side effect would be some redness or swelling at the injection site, which will subside in a couple of days. Occasionally people might get a headache, some fever, some muscle aches. Again, they'll only last for a couple of days. I guess with any vaccine, occasionally you can get a more severe reaction, an anaphylactic reaction, and that will be because they have an allergy to one of the components of the vaccine or possibly to egg.
I thought that was a myth about egg allergy and vaccines, Robert.
No, it's a myth in regard to MMR, measles, mumps, rubella. If you're so-called egg allergic, you can have MMR usually very safely, but we're still concerned about it in respect of influenza.
Is there any evidence that there is a problem?
Well, I guess the evidence, though limited, is sufficient to make the authorities concerned. It's in our handbook, so it must be right.
What's the story from parents? You know, he doesn't like eggs and pushes them away.
It's not like, it's that you can't breathe if you have eggs.
So it's anaphylaxis.
Anaphylactic. You know, and you know, a question would be asked, if you have an egg in a cake, can you eat it? You don't have an egg anaphylactic type reaction.
Of course, when we come to do our next food allergy one, the egg in a cake is very different from egg as egg, but that's another story for another day. Let's go to our first case study. It concerns Dr. Gupta, who works in an isolated practice, transport's unreliable, only sporadic internet connections. And this year some of his patients were asking why they need to be vaccinated, and he was also confused about the conflicting information he received from authorities about flu vax. What is this?
I've just got an interesting comment in relation to patients wanting to know whether they need to be vaccinated in relation to the fact that we have the same strains in our vaccination this year, and quite a few people are coming in and presenting in the pharmacy thinking that they don't need revaccination, and I think it's really important that we make sure that that doesn't occur and that people are really following up with revaccination.
But I thought it lasted 2 or 3 years. I mean, isn't it rational that you don't need to bother for if it is the same coverage?
We've got some good studies going back 50 years that show that you get protection into the second and even the third year, but probably only down to about 30 to 50% in the third year. You don't know whether you're the half that's protected or the half that isn't by the second year, and therefore it's better to have the vaccine than be sorry.
And there's no tachyphylaxis with the same vaccine 2 years in a row?
No, we don't have any evidence of that. What we do believe, based on the biology of the virus, even while it's infecting your body, it's mutating. It's an RNA virus. Its polymerase is very bad at copying itself, and so therefore it keeps making mistakes and looking different. And therefore some of those mistakes, not many, will lead to a change in the virus, and over time it will lead to a drifted virus for which you need more antibody directed perhaps against the slightly older one, but if you have enough antibody against the older one, you'll have enough to cross-react against the new drifted virus. So I think it's a good idea.
Well, the thought is that you need more antibody to deal with a drifted virus.
Exactly.
Therefore, if you're topped up, it's better. So that gives Dr. Gupta something. Should Dr. Gupta be immunised himself?
He most definitely should, and he should be looking at his practice staff, his nurses, his receptionists as being vaccinated. He himself could be working in the early stages of a flu infection and infect his patients, as well as protecting him from patients that come in with a flu injection. So it's very important that healthcare workers are vaccinated.
So the workload can be considerable, Karen, when things start going, you know, when the epidemic hits.
The workload
on professionals.
Absolutely, which is why if we vaccinate in advance, we can help reduce that.
So this is an isolated general practitioner.
Mm-hmm.
Where's he going to get his information from to keep up to date?
He's going to get it from his resources, like the handbook, which every GP should have on their shelf, and also from it's available on the internet. He will get information from his local divisions of general practice, and divisions of general practice have immunisation programs, and they are very proactive in keeping their GPs updated. Also his public health unit, he will have obtained his vaccine through his public health unit, and they will be keeping him updated. And if there's any concerns, adverse reactions, they will be sending out urgent fax streams, as they did in the flu vax situation last year.
And the one that is particularly useful is the influenza specialist group. That's got a lot of current information.
Yep, that's very good.
And is that a resource as well that could be, say, utilised by pharmacists who may be concerned about whether they should be watching out for early cases?
Yeah, that's a very good resource that's available to the public as well.
And those websites that you just saw there on the screen are going to be on the Rural Health Education Foundation's website, and so you can get to that, even if hopefully these days you're getting more consistent information, internet connections to be able to access it. What about Dr. Gupta's Indigenous patients, his Aboriginal patients, and getting effective services in there, or if Dr. Gupta is working in an Aboriginal medical service?
Well, that's really important because influenza immunisation is indicated for all Indigenous adults from the age of 15, and for children who have a high-risk condition. The hardest thing to do is to know who your Indigenous patients are, because some don't identify. So you've got to take measures to find out who amongst your clients, amongst your patients, are actually Indigenous. You can use IT systems to flag immunisations for Indigenous people. If a child's brought in unwell, then you can check the adult immunisation at the same time. So there's things to do like that. The public health units and the Aboriginal medical services can work together with Dr Gupta, perhaps, to do clinics and community events to promote immunisation. It's certainly worked very well through the pandemic. They can provide some extra hands to do clinics now and then. And then it's really important to make clinics culturally friendly, to have Indigenous staff to train people.
Can the panel please advise on who should be receiving oseltamivir? The Northern Territory advice is that people with risk for serious illness with influenza should be routinely prescribed it. We are still in the protect phase of the pandemic influenza response. This includes all Aboriginal clients. I wonder if this is the same nationally. Robert?
I think the logical way forward is to say, if you're healthy, if you have a mild illness, of course there's no need to prescribe it, even if you think it's influenza. If, however, you're in a high-risk group, you've got probable influenza, even if it's not been diagnosed, you need to treat early, within 48 hours of falling ill, if it's to work.
But the Cochrane review of Tamiflu found that it shortened symptoms by half a day, and that was it. No effect on hospitalisation, no effect on mortality, and you're probably going to increase resistance. Are we just spending money for no good reason here?
Well, my reading of the reviews is it's more like a day, but it's not much, I agree. And the same applies to children, in fact. I think it's worthwhile for the sick patient. When we first had antibiotics...
So this is an act of faith, Professor Boyd, is it?
We introduced penicillin in 1942 and the policeman got better. And likewise, we don't have the RCT evidence, but the evidence of our eyes is that people get better. I've treated nurses on my team and seen them recover within 24 hours of being really unwell. And I was totally shocked. So the evidence of my eyes suggests
well, it gets the slaves back to work, though, doesn't it?
Well, it's been great. I mean, I drive them.
Let's go to our next case study, who's Sally, who's 5 months pregnant and arrives on a flight to Cairns from London in February. And Leanne, you've just you've got the long straw, so you've got you moved to practice to Cairns in the sun. She's travelling with her 4-year-old son. She's been coughing, complaining of a headache and sore throat during the flight with aches and pains. And she asked the steward for some pain relief to ease the symptoms. And she's looking pale and has a fever. Who's going to pick her up if she doesn't turn up at your surgery?
Probably no one. I mean, we had temperature scanners in the pandemic and that we were told they were next to useless and could be easily overcome, and she was actually has probably taken some paracetamol on the plane. That's probably what the flight attendant gave her. And so, yes, but then she's got a 4-year-old in tow, she's feeling awful. She may faint while she's waiting for her luggage as it comes off the carousel after some period of time. Or the person who comes to pick her up...
Well, usually faint when it does come off the carousel, that's the usual thing.
But, you know, the person who comes to pick her up from the airport may notice how unwell she is and insist that, that they take her for medical attention.
Is it, let's say it turns out to be flu, we'll talk about how you're going to manage it in a moment. Is this notifiable, you know, given that she's come out of our flu season? Do we need to know about this, start ringing the bells?
Well, look, I think most people take a good travel history, at least for the 1 week before they come to the surgery. And that's really important because we've had patients...
Hold on a second, do you take that, Leanne?
Well, not always. Sometimes we know because when they come back in, we say, oh, and how did the holiday go? But we really should...
It's unusual having a tan in Launceston, I know.
It is. Yeah, we should really incorporate that into anyone who presents with a febrile illness. Have you travelled recently?
Also, though, is there any procedures within air traffic control and flight attendant land that would mean that they would report that
Well, you're
illness?
supposed to write it on your incoming form, but I don't know who does that.
And on your incoming form it says present, if you have a febrile illness, present to a doctor, mention it.
So Sally's been a conch and she's turned up at your surgery. What are you going to do for her?
Well, because she's going to tell me this history that she's been overseas, and I'm going to be concerned that she possibly has influenza, and she might be the person who's the start of the pandemic, that I would convince her that it would be useful to have a swab. I would feel that I should ring my local public health office and just alert them to the fact that this person has been on a plane and travelled in with that, and they will leave them to sort that out after that. And she's pregnant, and that is a concern, that women who are pregnant were much sicker in the pandemic than others, so we would be talking to her about having Tamiflu.
And what about the child? You're going to immunise the child, Robert?
No, because the child would probably fall ill before the effective immunisation could take hold.
What's the incubation time versus the effectiveness time of the vaccine?
Yeah. If you're exposed, the incubation period before falling ill is as little as 24 hours with influenza, and perhaps up to 5 to 6 days. A vaccination can work in 7 to 10 days, so it's not going to be the way to deal with this. And in terms of the notification, that's not done by doctors routinely, but if they're concerned, of course they should tell their public health unit. But if the lab finds the virus, it's their role and responsibility to notify that.
What's the approach to air travel in general? Because we've got a question here from a general practitioner in Yass in New South Wales. Should we automatically vaccinate all patients who we know are about to travel overseas?
I think that's an excellent recommendation to do that. And when people come in to discuss travel, and unfortunately people don't come in often enough.
But hold on a second, if you're travelling overseas in July, you're not going to the northern flu season.
But you're travelling with Australians who may take you may take the flu to the Northern Hemisphere with you.
And Karen, it's quite high, the infection rate on a jumbo jet, isn't it?
Apparently so. There's some studies where one person has been infected in the past where they infected 72% of the population, but I think Robert's had figures on
well,
how many
a more average figure is 15 for every 500 passengers, so that's still a lot. That's, what is it, 3%?
So 15 on every 380 jet.
It's a lot.
It's amazing.
I've certainly been infected on a plane.
Class.
I've certainly been infected on a plane, and I've certainly been so ill from influenza that after giving a talk I almost collapsed and put a blanket over my head and flew back home.
Was that responsible, Robert, for you to get on the plane if you knew you had influenza?
Well, I thought with a blanket over my head and accepting no food and touching no one and talking to no one, I'd be okay.
Again, you know, you have to sort of question the procedures of the flight staff. You know, should they be a little bit more aware of that? I'm not sure.
But they may get on okay. A flight can be 24 hours and they deteriorate while they're there.
And the other preventive things are things like be aware of hand hygiene when you're away, steer clear of people like Robert Boy, that sort of stuff.
Not always easy if you're in economy class.
No.
Would they come along and put a mask, though, on that person who was coughing if they didn't have one themselves?
I don't know if they would in the current climate. They would have done in 2009 when we had pandemic. Flight staff were very alert to it.
So let's just talk about prevention while we're here. What is the role of face masks?
Face masks, if you are the person who is coughing, will prevent to some degree, particularly the P2 and the N95 mask. This is if they're worn properly and they're not worn for an extensive period of time. A lot of people in the pandemic were wearing face masks to protect themselves, which unless you're a healthcare worker is of probably little use walking down the street wearing a face mask, and often they were wet and soggy and they need to be changed frequently as well.
And what about staying at home, not going to school, all that stuff, Robert?
I think that's good, sensible stuff. You don't need to go to the GP if you've only got mild to moderate illness. And there was advice to have fluids, take antipyretics, rest, and not infect the rest of the population, including the waiting room of the GP's surgery.
I mean, certainly we have a lot of people presenting with mild to moderate symptoms, and you just have to reassure they have to treat their symptoms. And
do we know the difference between washing with soap and water versus an alcohol gel for the influenza virus?
I think the key point is how long you do it. You really need to do it for 15 seconds. And if that's with soap and water for 15 seconds, you'll get a good result. If it's a proper dollop where you use 15 seconds with the alcohol, I think that's what makes the difference.
Right.
And you don't forget your thumb. Isn't that the big forgotten spot?
Thumb in between your fingers.
the
I guess so.
Community nurse, Sharon, a community nurse from North Queensland, asks, how can we encourage more of our Aboriginal clients to get flu shots? I think I'll answer that with no expertise, but my suggestion is that your Aboriginal health workers are the ones who actually you deal with in the community to actually gain access. I think a non-Aboriginal general practitioner or community nurse trying to tell, to talk to the community is going to be difficult. Sort of, and that cultural sensitivity that you were talking about earlier, Robert, is one of the answers there. This is something that's got to be done with the community and controlled by the community.
And too many Indigenous people got very ill and died every year, let alone during the pandemic.
So it is an issue. Sorry,
and
Karen?
notifying them that flu doesn't discriminate. I guess it's the same education programs. Yes, there's some greater needs with the Aboriginal community, but they're across the board. You know, what are our common myths? Why don't we get vaccinated? We don't believe we're at risk. You know, we believe we'll get sick from the flu vaccination. All of those. Find out, uncover them, address them, keep taking home the same message that vaccination is still the best thing to do.
Another question from a nurse in aged care in Victoria. Should we get all our patients in the aged care facility vaccinated as standard prevention, Karen?
Absolutely. And it's funded. Most of them will either be over 65 or they'll be compromised. But more importantly, the question should be is that every one of those people that come in contact with that patient, every staff member in direct care should be vaccinated. We know the flu vaccine doesn't work as well in the over 65, so what we need to do is to relate that duty of care as a healthcare worker and say, I'll protect myself even if I don't think I'm at risk, so that we don't hurt our patients.
And standard cross-infection and hand hygiene is a matter of routine in aged care facilities.
Yeah, but it is very important that this group is vaccinated to protect the other residents and the staff.
Absolutely.
Because sometimes that issue comes up. These people are, at the end stages of their life with advanced dementia. What are we trying to achieve? And we are trying to stop an outbreak.
Yeah, absolutely.
I'm a paediatrician with an interest in the elderly. For 3 years we ran research. We looked after 9 different outbreaks of influenza. We learnt so much about the prevention of flu. One is that the vaccine works about 60%, and therefore you can still get outbreaks. And therefore it's important to take all those other measures very seriously as well.
So herd immunity becomes very important.
It is. And staff.
Let's go to our third case study. 28 years old. She's Sarah, who's 8 weeks pregnant with twins. She comes to you, Leanne. You're back in Launceston now. Your locum at Cairns is over for her first examination. And this is her first pregnancy. She seems in quite good health. She's rarely ill, she says. And she actually doesn't want to have the flu vaccine and doesn't know much about the new flu strains. And she's just started working in a fairly large office. What are you going to do about
I'm going to talk
Sarah?
to her seriously about the safety of the flu vaccine, and that it is a very safe vaccine. I'm also going to point out that
it is safe in pregnancy?
It is safe in pregnancy. We have good evidence that it's safe in pregnancy, given after the first trimester. And we are trying to protect these women who are likely to give birth in winter. So we're going to give it to them in their second or third trimester. She also works as well as being pregnant and therefore at greater risk of complications of influenza. She's working in this big office with 1,000 people, I believe, and so therefore she's in contact with so many more people. Like our jumbo jet story, there are going to be people who go into that office who are coughing and spluttering and are going to put her and her baby at risk.
Big news, an office plot with 1,000 people in Launceston.
Yes, it certainly is. We look forward to that to help our employment situation. But also the other thing that I was going to say is that it's really important that we as her GP and the midwives and all the people caring for her tell her the same story and reinforce that, because there's evidence shown that they are more likely to do it if it is recommended by their GP, their midwife or their obstetrician.
Can I just interject? The flu vaccine is safe in the first trimester. Our handbook will state. We're aiming at protecting them in their second and third trimester when they're likely to have complications, but it's absolutely safe, and that's what we have to get across, and it's one of the few things that our immunisation handbook will recommend in first trimester.
And there was no difference in the 3 types of vaccine in pregnancy, in pregnant women. It was only in children.
Oh yes, once you got above 5 years of age, the differences were very little, and certainly above 9 years, there's no concern whatsoever. So I had my CSL flu vax last week. I asked after I had it, and they told me what it was.
Robert,
so I was fine.
What's weather got to do with it? Is a wet winter or a wet summer going to make it more likely that flu occurs? I mean, it's not carried by insects, so
no.
What's the story?
The epidemiology suggests that when you have cooler or wet weather or both, people spend a lot more time indoors, they spend a lot more time in cramped, crowded conditions, and of course they're more likely to transfer infection and transmit. So I think it's...
So it's wet weather indoors as they cough and sneeze over each other?
Absolutely.
Rather than what's outside. So we've talked about hand hygiene and masks and so on. So we just, And we've talked about the coverage this year. It's the same as last year in the strain. Let's just now go to our final case study, which is Mr. Jacobs, who's come to you, Leanne, because he's been recalled he's on your recall system for immunisation. But since you last saw him, he's actually had a partial pneumonectomy and chemo for his lung cancer. He's also type 2 diabetic, and he's had a year on chemo, and given that he's still going a year afterwards, he's doing not too badly, and he's not too keen on this immunisation because he's been told by his oncologist that his immune system's compromised, and he's worried that you're going to kill him with the vaccine.
Yeah. We're not going to do that. The vaccine is not going to affect him. It may not be quite as effective, so this brings up another issue of protecting the people around him, and particularly his carers. You know, if he has a wife, if he has children at home, particularly grandchildren, he may have some grandchildren, that they all should be vaccinated, really as a way of protecting him from the vaccine, but he should still have the vaccine himself.
I think that's a lovely story, because right now in many states of Australia, people are encouraging parents and grandparents to be vaccinated against whooping cough to cocoon the baby. But we can likewise cocoon the elderly person against influenza by vaccinating the family members.
And I believe in Japan they actually vaccinate the children because...
They certainly did as a routine in school age in the past, but it's not routine anymore. But when they looked at when it stopped, there was a lot more elderly infection when they stopped the school-age program.
I think it's particularly important, isn't it, for the immunocompromised patient, because...
But does the vaccine take in somebody who's immunocompromised?
Well, look, as Leanne's suggesting, it doesn't work as well, but we do know that you do get some benefit. When we did a study just recently in aged care, these were all people between basically 75 and 100. We got 60% protection against a mismatched strain. It wasn't perfectly matched at all. So I think 60% protection when the vaccine you're using isn't well matched to the seasonal strain says this is worth doing. And it's worth giving to everyone in aged care and everyone who is not in aged care but has a chronic medical condition.
Such as his grandchildren.
All contact.
Tell me, one of the issues here is administering vaccine. It's different in different states. Tell me about your fascinating trial that you did in Tasmania, Rachel.
Oh yes, the Pharmaceutical Society partnered with the Department of Health and Human Services as part of their general desire to vaccinate up to 30%, I believe, of the population. Basically, it was chosen for pharmacies because people who rarely visit the doctor, so a lot of the target group, I guess, for especially for swine flu vaccination, are not people who necessarily go and see their doctor regularly. And from the trial, about 30% of people said that they wouldn't have had the vaccine unless it had been available within the pharmacy. I think it just is because people walk in and the clinic is going on, that, you know, there's an opportunity for ad hoc.
So give me a sense of how you organised things and then what the results were.
Okay, there were nurse immunisers who were contracted to work within the pharmacy, and obviously there are a few administrative lessons learnt in relation to rolling out such a program, but I think it's really important that the pharmacies should be considered in the future as, you know, part of the bigger picture. There's quite a few pharmacies since the program and around the time of the program in the north of the state who have been coordinating and organising with the GPs and immunisation nurses in their area to provide just an additional option. Certainly the immunocompromised patient who rocks into the doctor's surgery where there's a lot of other sick people that may... I'm not saying that necessarily it's the right environment for them in a pharmacy either, but I think that it's a really, in relation to being something that we can platform off. In the US, over 90% of pharmacies are involved in immunisation for seasonal flu. By the pharmacist in the pharmacy, and 50% of the vaccinations are actually given in that way.
I was going to ask you, Leanne, I mean, was it smart to recall Mr. Jacobs, given, well, you didn't know, but I mean, if you had known, presumably you would have known actually if you had a partial pneumonectomy, to your waiting room when it might be full of people with flu.
What would be ideal for Mr Jacobs would be for him to come to a special flu clinic and general practices.
Is that where you can catch flu specially?
Yeah. No, we're a flu vaccination clinic where they could actually have just a dedicated time when we were basically having well people coming in, seeing the practice nurse in a lot of cases or the GP and having a vaccination.
And minimal mixing.
And minimal mixing. And often when those sorts of things are structured, there's a separate waiting area for that because the practice nurse is doing it.
You had a similar experience in Melbourne, didn't you, Karen?
Very similar to that. Like, it was H1N1. I ran a few clinics in some pharmacies. Basically, with the pandemic, we had a free vaccine, but we didn't really. The service delivery in Victoria, anyway, was only through the GPs, and they were busy. So I saw it as a way of getting the vaccine to the healthy well that don't access their GP. The clinics in the pharmacy went very well, but they were heavily advertised by the pharmacy. I also ran a clinic at Melbourne Town Hall where we had no prior advertising. I had my teenage sons handing out flyers out the front. But over a few hours, I think we vaccinated about 400 people in a 3-hour block. That was
the Lord Mayor turned up, did he?
No, the Lord Mayor did not. But I think the whole point is there are certain population that don't access their GPs. They're healthy, they're well, and if you take the vaccination to community or workplace.
I think the key, as you say, is as long as it's well coordinated and well advertised. We found that in the trial, those pharmacies who had very good administrative support had a really high rate of vaccination and very
Karen,
successful.
how did you get on with potential complications, adverse reactions? From simple like a vasovagal to somebody having an anaphylactic reaction?
Certainly, I think we've learnt from the trial. We had a vasovagal reaction in the pharmacy when we were conducting the trial. I think it's really important there for the immunising nurse to be supported within the pharmacy, within that structure, and appropriate other staff dedicated to the task.
So there's got to be a reason, so that you're presumably just managing the burden on you as a workforce here to deal with that. What other workforce options might there be, Karen?
Sorry, I actually wanted to just go back. Can I just go back just a second? But like in Australia, you cannot immunise remotely without a doctor's order unless you're qualified. That means you're a registered nurse with post-basic immunisation qualifications, which means that we have the skills to manage anything from a vasovagal to an anaphylaxis. We carry the appropriate drugs that we need, and we're skilled at picking up those knowledges. So just going back, I think it's just having the appropriate staff in those.
And also, like, I mean, because of maybe the immunising nurse not being fully in line of recovering people, then, I mean, you have the staffing available.
That's actually her responsibility too. When we take on that role to do that, we're aware of all of that and positioning ourselves so that we can see and can manage them.
Because it wasn't an issue.
So, Rachel, I've got a question from you from a pharmacist in Queensland who asked, were particular pharmacy clients targeted, or was it a general approach?
Was well, certainly in our area, in the first phase of the trial, there was general advertising in local community papers within the pharmacy.
Out the front?
Yeah, within the pharmacy, posted really well trained, motivated staff who basically just asked every single person who came in, had they had their vaccination and did they want an appointment and what time would they like it. So it was a lot of word of mouth.
And did you have to set aside a room, or how did you do it?
Well, we're lucky enough to work in a pharmacy that has quite suitable private consulting rooms, so it was more than appropriate.
So you didn't have to do it between the hairspray and the toothpaste?
No, we didn't. But also we took walk-ins, and the immunising nurse, I think some nurses vary in what they, sort of prefer in that situation. But I think that the big thing in relation to further programs would be that to really capture the cohort of people who aren't seeing their GP, the ones with chronic illness, is to sort of really look at after hours and weekend vaccinations, because the timing meant that you really did lose a lot of people, I think.
Robert?
I just wanted to add to what Karen said, that if there are registered nurses watching and interested in getting training, there's a lot of different ways to get training across the different states of Australia. If you look at the National Centre for Immunisation Research, there's a regular there's a website, and you can go to as a health professional, you can go to the immunisation professionals site, and there was considerable discussion about that through January, February, and so you can follow that and see what's appropriate to your state if you're interested in being trained as a registered nurse to become an immunisation provider.
Stephanie, a community child health nurse from Bendigo, Victoria, asks, is it likely that free flu vaccinations will be offered to school children like they did in the ACT last year?
Wasn't ACT or WA?
Well,
look,
somewhere?
Certainly the WA has been using it for preschool children from 6 months to 5 years for the last 3 years, and this is the 4th year. In terms of school children, theoretically that's a great idea, because from the Japanese experience you could get not only benefit for them but for their families and for the wider community. It's unlikely in the near future that Australia will, under the National Immunisation Program, provide free immunisation to healthy children or adults.
What are the commonest myths you come across, Karen?
That you're going to actually get influenza from the flu vaccination, but it's not a live virus, so that's impossible. That I'm healthy, so therefore I don't need the flu and the flu vaccination. Like, they don't perceive the risk. People perceive it as being for the older population. Lots more. Someone else help me out, but they're the same.
Well, when you come into a waiting room, there's always the chance that you could catch a virus there and then, whatever virus, let alone flu or an adenovirus or a paraflu, and then 2 days later you've had the vaccine, you feel really unwell, sore throat, runny nose.
Dangerous going to the surgery.
Well, it could be. But it's also important to know that the side effects that you think are flu after a flu jab, which might be muscle ache, headache, fever, well, those are from the vaccine without it having infected you at all, because you don't have a runny nose. It's your interleukins, it's your cytokines, but you don't have a runny nose, you don't have a sore throat, you don't have a cough, so you don't have respiratory symptoms. And many people call those systemic symptoms the flu, but it's actually a side effect of the immune system dealing with the virus in the vaccine.
It's just really important that anyone involved in healthcare is singing the same song, as far as making sure that any misconceptions, that the picture is very clear.
They don't sort of feed on that thing and saying, oh yes, well I wouldn't have it, because the other people come and say, oh, I was really unwell after it last year, I don't want to have it this year, or I was really unwell and I had it back in 1962 and therefore I was told by the doctor in 1962 I shouldn't have it again, but in fact that's often not the case.
What community education campaigns can people...
Well, the other thing is, if you're vaccinating, as you're vaccinating, if you remind them, like, I don't think there's anybody that I vaccinate that I don't remind them of those common side effects. That's once you've got them to be vaccinated. Remind them of that, so you don't get
now
that
there's the bad news.
No, but so that you don't get them coming back next year and blaming the flu vaccine.
So we'll expect that you will have a sore arm and you may feel have some muscle aches and pains, and we can suggest some things they can do for that.
For especially as a pharmacist's role for quality use of medicine, certainly that's pivotal, and that should be happening every single time.
What community education programs can people expect to see over the next few weeks?
Well, certainly within community pharmacy, I would expect, I'm not sure whether there's a dedicated program. I should imagine the Guild will be encouraging, Pharmacy Guild will be encouraging people to actually advertise and promote within the pharmacy. But yeah, we've brought out the old posters.
And there's new posters being supplied to us by the federal government, by the immunisation specialist group and by some of the vaccine providers. And the local divisions of general practice, certainly in Tasmania, we have an active campaign of contacting our doing a media release. And one of the good things that we sometimes do in that media release is having a doctor having a vaccination. And I think it's always a good message to give to your patients, see their doctor having their vaccine, because so often when you're talking to them about it, they say, well, have you had it, doc? And when you can say, yes, I have had it, or you might say, I am waiting until the supply comes on board for me to be able to have it. But nevertheless, advertising, have it. And our families have it.
Advertising in school newsletters, if you're in a community where, you're sort of actively involved in all the community groups, to schools and sporting organisations as well.
So, you've got no excuse. Get in with the campaign, get on and do it. And you know where to go, or if you don't know where to go, you can go to the websites, and we'll come back to that in a moment. But thank you all very much. It's been fascinating. What take-home message have you got for people watching? Karen?
Vaccination is your best defence against influenza. Influenza does not discriminate. Vaccinate to protect you, your loved ones and your colleagues.
Yeah.
We're good at vaccinating the over 65s. We now have to think about those other groups, the chronic illness, the pregnant ladies, the Aboriginal and Torres Strait Islanders, and a big plug for the healthcare workers.
And I guess pharmacists should be really seriously considering about how they contribute to the healthcare team's message, and be really considering actually targeted approach within their pharmacy and data mining and just assisting target those that are missing out.
Robert?
Paediatrician, I'm an advocate for children. We know that the vaccines made available this year are safe and likely to be very effective. If parents want to have their children immunised, then they should avail themselves of the opportunity.
And I hope you've got a lot from this programme on influenza. Our thanks to the Department of Health and Ageing for making the programme possible, and thanks also to you for taking the time to attend. And if you're interested in obtaining more information about the issues raised tonight in the programme, there are a number of resources available on the Rural Health Education Foundation's website, rhef.com.au. Don't forget to complete and send in your evaluation forms to register for CPD points. I'm Norman Swan, and I'll see you next time.